students, I am Dr. Pavithran, Assistant Professor from the Department of Oral and Maxillofacial Surgery from Vinaka Mission Shankaracharya Dental College. Today, I'll be taking you through the topic Apicoectomy. So, Apicoectomy is a procedure which comes under the part of endodontic surgery. So, let's see what endodontic surgery is all about. Endodontic surgery is a dental procedure that is used in the treatment of apical periodontitis or large cyst, where non-surgical treatment such as root canal treatment is not going to offer you best results or it results in a recurrence. So in that cases, we have to go for surgical treatment. So that is called as endodontic surgeries, wherein we go surgically in the periapical region of that particular infected tooth and remove all the contents where like the granulation tissue, the granulomas that are formed at the periapical region, and clean the pulpal chamber, and we create a seal in the apex of the tooth. That is all about endodontic surgery. So today we'll see about step by step how this procedure is done. So as I mentioned, apicoectomy is cutting off the apical portion of the root and curating the periapical necrotic granulomatous and inflammatory tissues along with the cystic lesions that are there in the periapical region of an infected tooth. So when you have a chronic pulpitis that has resulted in apical periodontitis, over a period of time, it turns a periapical abscess granuloma resulting in a periapical cyst. Even when not treated, this results in a periapical cyst which are larger in size that is not going to respond towards a conventional non-surgical treatment modalities. RCTs, if done also, is going to result in failure. So along with RCT, we have to combine surgical treatment called as apicoectomy, where we go in the periapical region, open the flap, open the bony window, see the apex of the tooth, curate all the cystic lesions, remove all the infected tissues, remove all the granulomas or the infected tissues that are attached to the apex of the root, and surgically you cut the apex of the root for certain millimeters, which I'll be telling you how much millimeters and all. You have to cut it and create a retrograde seal with the appropriate material so that the infection doesn't track back into the root. So it is surgical treatment that is combined with conventional non-surgical modality in a long-standing chronically infected pulpal pathology infected tooth. So here we are going to address the intraradicular infection. Also, we are going to remove the etiological factors which is constantly causing the infection. So the indications of apicoectomy are failed root canal treatment, large persistent lesion after root canal treatment in the periapical region, and there are procedural errors which can commonly occur during any root canal treatment such as perforation, instrument breakage, ledging, all. And if there are any anatomical variations, radicular areas such as calcific metamorphosis and severe root curvatures, all of these are the clear-cut indication to perform apicoectomy. But the most commonly used in the clinical scenario is failed endodontic treatment or large periapical lesions which do not respond to a conventional non-surgical treatment. The contraindications are the anatomical constraints where the root accessibility to the root is very, very difficult, and the root or the lesion is in close proximity to the important anatomical vital structure such as a nerve or a vessel, and patients who have systemic health issues where surgery is contraindicated, and tooth-specific factors. The common armamentarium that is required to perform an apicoectomy are simple. You should have a micromotor with a burr or a surgical straight handpiece with burr to cut the root apex, and general surgical instrument to open up the flap and expose the periapical region, curates to cystic lesion or the granulomas that are formed, and you have to have some ultrasonic tips after the root resection procedure to create a radicular cavity wherein you can fill the biomimetic materials that create a good seal and offer better prognosis, and the suitable materials for root infilling. So these are all the general armamentariums that are required to perform apicoectomy. So let us go through the steps of the surgical procedure. The first is the design of flap. There are n number of flaps. We'll see one by one. And after the flap is opened, we have to locate the apex of the tooth. So we have to expose the bone. If there is a bony window, already the lesion has caused a bone resorption. It is easy. You can directly go and locate the periapical region of the tooth. If not, surgically, we have to create a window. After once you have located the periapical region and the content, the next step is to remove all those infected tissues. So once you have clearly removed, the next step is to perform a root end resection. After that is the retrograde filling, followed by wound cleansing and suturing. So these are all the steps of the procedure. So let us see one by one in detail. So first is about flap design. What are all the prerequisites of any flap when you perform an apicoectomy? So the first and foremost thing is you should have adequate access and visibility. So we cannot work under tunnel. So we have to have a clear picture, how much clear area of infection, clear demarcation between healthy and infected tissue, and we should have adequate access to approach that and treat that area. So for that, you should have adequate access, illumination and visibility. There is a general principle that the wound heals along the line of incision, not along the length of incision, which means that smaller is the area of incision doesn't mean the wound heal faster. So it heals even if it is 1 centimeter or 2 centimeter or 3 centimeter, it heals along, and the time taken for the healing for the whole of the incision is same. It doesn't matter how much is the length. So we can have a wide area of exposure and adequate access to the surgical field. So the next is you have to have adequate care should be taken to minimize the trauma to the soft tissue. In other words, the soft tissue should be handled very gently. So once your procedure is done, the soft tissue has to be re-draped to its original position and it has to be meticulously done. The second is proper blood supply for proper healing after your procedure. So your flap design should be in such a way that after the procedure, the flap which you have reflected receives adequate blood supply so that the post-operative healing is not hampered. So there are several principles of flap design which are not going to cover in this. So that has to be kept in mind while you are raising a flap for performing surgery. The second is so this also aids in preventing post-operative complications like wound adhesions or scarring. And the flap design should be selected based upon the area where you're working, whether it is an anterior region or a posterior region, whether it's a maxilla or mandible. So depending upon the anatomical area where the surgery is performed, the flap design varies. So the first and the foremost flap incision that is used to create a mucoperiosteal flap, the basic one is the semilunar incision. So the semilunar incision, as it is mentioned by the name itself, it is half moon in shape. In the tooth we are going to work just above the attached gingiva. So you have free gingiva, you have attached gingiva, and you have a mucogingival junction. So just above the attached gingiva, leaving a cuff of tissue for suturing back, you create a half moon shaped incision to the depth of the bone, incising the periosteum. All the flap design, you have to create a mucoperiosteal flap. So a slight curved half moon horizontal incision is placed in the alveolar mucosa, that is above the attached gingiva, that is beneath the mucogingival junction. Advantage is that the incision is very small in size, but it will be like you are working in a tunnel. So you have limited access visibility, and challenges are there in reapproximation. So if you're not giving adequate cuff of tissue towards soft tissue is not left for adequately for suturing towards the tooth area, then you're going to be in trouble, because suturing in the attached gingiva is very, very difficult. And the more complication, one of the most complication that is seen with this is about scarring. So this is not widely used for the procedure. The second is a intrasulcular incision or a clavicular incision. So you put an incision along the clavicular margin of the tooth that is infected, and also you extend 1 or 2 tooths on either side, so that when you retract, you have adequate visibility as well, and there is no trauma to the soft tissue. Otherwise, when the incision is very small and you retract for access, the soft tissue can tear. So it has a very good access, very good visibility, and the post-operative pain, swelling, scarring is not that much seen, and there is good reattachment to the bone as well post-operatively. But the only thing is, since we are giving an incision in the clavicular margin, if there is no proper reattachment, then there can be post-operative problems like gingival recession. So reattachment is a very crucial step in an intrasulcular incision. So the third most technique is a papilla-based incision. So it is a modification of an intrasulcular incision, where the complication that we have seen with the intrasulcular incision is about the gingival recession. So here what we are going to modify is about, we are going to preserve the interdental papilla. So papilla, we instead of creating a clavicular incision, we cut the crevice, and in the papilla we make a horizontal incision. So in that way, the recession and the papillary detachment can be prevented, but is again technique sensitive and not widely practiced. The next technique would be a submarginal incision, which was developed or propagated by Oceanbean and Lubeck. So it is a horizontal submarginal incision instead of a clavicular incision or an intrasulcular incision. The problem of gingival recession can be avoided with this technique, where you create a horizontal incision below the marginal gingiva or in the middle of the attached gingiva following the shape of the clavicular margin. So it is indicated where your attached gingiva is wider in region so that reapproximation can be easy. If your attached gingiva is very narrow, this technique cannot be used. So it is contraindicated where the surgical access is limited or a large periradicular lesion is present. Postoperative scarring is again a problem. So I would prefer to go for a intracellular incision or a clavicular incision with vertical releasing incision resulting in a trapezoidal flap. So if you are meticulously resuturing the interdental papilla, the problem of gingival recession could be avoided. So once the flap is elevated, the next step is to locate the area where we are going to work. That is the periradicular region. Lesions which has perforated or penetrated, which are long standing, which has thinned out the buccal cortex, this will, once the flap is elevated, you can clearly go to that area. But if it is a acute lesion or lesions which are not capable of penetrating the bone resorption, causing a bone resorption, from the preoperative imaging like a OPG or a CBCT, we will have to identify which region we can go and create a bony window. So we have to use HP8 round burr with a surgical micromotor to create a bony window of adequate size. So care should be taken not to puncture the cystic lining or the granulomatous tissue. So which will again cause a naggy area of surgical field constantly bleeding and creating disturbance to our procedure. So care should be taken to create a proper corticotomy and remove that particular area of bone. So lesions which are fully contained, that's what I was telling, the bone has to be removed and the apex has to be localized. Lesions which have penetrated the cortical, it is very simple. You can directly locate the periradicular region. So radiographs in between, you can, if you are finding trouble to locate, in between IOPS, CBCTs can be used to locate the area of surgery. So keep in mind, whatever area you're working, the nearest anatomical vital structure should not be injured. So that is one main surgical principle to be followed. So in the principle of locating the abscess, the first should be you should have adequate visual and surgical access to the field of area of working, and the aperture that you're going to create or the bony window that you're going to create should be at least 8 cross 10 millimeter and 3 millimeter in a microsurgery. When you're doing a microsurgery under loops, or if you're doing under visible eye, it should be at least 8 cross 10 millimeter, which is cross 1 centimeter. Bony window should be used if you're not using a loops. So lesions which are less than 5 to 8 millimeter in diameter, after this procedure, they have complete bone regeneration capability. So defects which are more than 9 to 12 millimeter, that is more than 1 centimeter in cross section. So what will happen is there can be herniation of fibrous tissue. So that has to be meticulously delineated from the normal tissue and it has to be removed. So radiographically, there can be direct relationship between the osteotomy size and the speed of healing. So when I was talking about the flap design, I asked you to make a wider flap and healing is not going to be hampered. But when you create a window, keep in mind the size of the lesion that you have determined from the preoperative radiograph. An adequate size of window alone you create, because bone regeneration is something which will take, if the defect size is smaller, healing can be faster. If the defect size is lesser, then it is going to take a larger period. If the population that you're going to address is a pediatric or an young adult, bone regeneration can be in an accelerated fashion. If you're dealing with an adult population, then bone regeneration is going to be very, very slow. So do not unnecessarily create extra defect to the bone. So once the bony window is created, you have to distinguish between the root and the surrounding osseous structures, that is your bone. So it is very easy to delineate. So according to Barnes, he has given 3 criteria. So the root structure will be yellowish in color, whereas the bone is going, we know the normal color of the bone, which will be whitish yellow, whereas the root is usually yellowish. So the roots will not bleed when you probe, whereas your bone will be soft and it is going to bleed, especially in your maxilla. And the texture, it will be smooth in the bone, and it will be granular or porous in the radicular area because you have attachments to the cementum, right? Perial gets attached. So with this, you can grossly delineate, but delineating root and bone should not be a problem. It can be easily done with routine practice. So once the area is approached, the periapical area of interest is delineated, bony window is created, and the radicular and the surrounding tissues are demarcated. The next step is to curate completely the area of infection. So the aim is to, if there is granulation tissue or if there is a cystic lesion, the lining has to be completely removed. If you're leaving some part of the lining, there are high chances of recurrence and failure from your endodontic procedures. So complete debridement or curettage is very, very essential in the periradicular area. All the lesions should be removed. So if multiple tooths are involved, all the interradicular area should be curated very properly. So one of the clear indication that you have created is once you have curated the cavity or the periradicular and there is no soft tissue attached, that is the granulation tissues are completely removed, the cavity will be very clean without any bleeding. If there is some part of tissues that are left, there will be constant bleeding. Curates which are specially designed to use in the interradicular area can be used to do this, or you can use gauze, dry gauze pieces and scrape all the radicular surfaces and the interradicular area, and the bony cavity should be free of the cystic lining, granulation tissue or any sort of infections that are present. So once this is done, the next step is since this periapical, the root apex is constantly in contact, we are cutting a end of the root and creating a retrograde seal. So factors that are to be considered when you are performing a root end resection are the proper instruments that is needed to resect and refill that area, extent of the root end resections. You cannot go and cut as much as you like, and the angle of resection, the bevel or non-beveled resections. So the first is instrumentation. Ideally, the number 51 straight Fisher burr or a Lindemann burr or a multi-fluted carbide burr, or if you have a piezo access to a piezoelectric trip, it is very well and good. You can straight away use that. Otherwise, if your piezoelectric unit is not available, then in that case you have to sort for your burrs. So your three burrs can be used: straight Fisher burr or a multi-fluted carbide burr or a Lindemann burr. This is an instrument that is used for root end resection. The extent of root end resection, how many millimeters of the periapical root that has to be resected, it depends on it can be 1 millimeter, 2 millimeters or 3 millimeters. It depends greatly on the presence of apical ramifications and lateral canals. So from your preoperative radiographs, you will have an idea if that particular root is having a lateral canals or apical ramifications. So the main idea after root end resection is to create a seal in that region. So for example, you have lateral canals in the 3rd millimeter of a particular tooth and you have cut only 1 millimeter or 2 millimeter and you have sealed it. Through the lateral canal, infection can again seep in. So that is the main ideology, whether you cut 1 millimeter, 2 millimeter or 3 millimeter. So it depends on apical ramifications and lateral canals, which can be easily predetermined from your preoperative radiographs, right? The next point to be considered is the angle of resection. Earlier, it was thought that root end should be resected at a 45-degree angle to create a bevel so that you can have an adequate seal. But recent studies show that there should be a 0-degree bevel, or at least only 0 to 10 degrees. So current recommendation tells you to resect the root at a 0-degree or 10-degree bevel rather than the older conventional method of 45-degree bevel. So here the main advantage is that you preserve as much as a root possible. When you angulate it, the more the surface you're going to cut it off. When you do not angulate it, you cut it only 0 to 10 degree, you conserve the root structure so that you have adequate crown to root ratio. So if your root is very short and you cut 3 millimeters with the bevel, you are going to compromise the radicular portion of that particular tooth. So 0 degree to 10 degree is all sufficient with recent literature evidence. So with regards to root resection, you have to keep in mind about the instruments that you are going to use, the amount of resection that you are going to do, whether it is 1, 2 or 3 millimeter based upon the apical ramification or the lateral canals, and the bevel of resection, whether it is 45 degrees is obsolete, not used. It is only 0 to 10 degrees that is recently recommended. So once the root end is resected, the cavity is curated, there should be no bleed. It should be ideally clean. So you can inspect that particular area. Complete hemostasis should be achieved before filling that. You can inspect that area by soaking with cotton pellet with epinephrine, which is usually adrenaline. Have adequate hemostasis, because your filling material is not going to stay if it is constantly being wet by the source of bleed or saliva. So adequate isolation is very, very important. So commonly used agent to inspect whether some tissue is left is ferric sulfate or aluminium chloride. So you can use that as a dye to check if there are any soft tissues, and further if it is there, you can cure it completely. Methylene blue thiazine based dyes can also be used to stain the resected root surface. Once that is, the dye will stain the circumference of the periodontal ligament, and it helps in verifying the complete resection of that particular tooth. Also, it helps in detecting your missed canals, microfractures, isthmuses, or any other anatomical variation. So that this can be used, but routine commonly does not perform. So once the cavity is curated, root end is resected, and complete hemostasis is achieved, and the area is clean, then you jump into the procedure called root end preparation and root end filling, which is usually performed by an endodontist. So here the ideology of preparing the root end is to disinfect all the apical portions of the canal that has been left untreated, and you create a class 1 cavity with walls parallel. It is best done with experts. That's what I told. This is done usually by an endodontist. So they do it with ultrasonic tips, create a class 1 cavity where the walls are parallel to each other, and you have sufficient retaining mechanism to retain the root end filling material. So the next step is the retrograde filling. So the purpose is to establish a seal between the root tissue and the periapical area, and there is no further seepage of infection in the periapical region. So according to Gardner and Dawn, a suitable root and filling material should have the following characteristics. It should be able to create a 100% seal. No leakage of bacteria and the byproduct should enter into the periradicular area. It should be non-toxic, non-carcinogenic, biocompatible with the native tissue. It should be insoluble in the saliva or oral fluids. It should be dimensionally stable, unaffected by moisture until setting happens. It should be easy, and it should be radio opaque to be detected in the radiographs that you take in the post-operative period to see any sort of healing. So the traditional one that were used, I'll just go to the brief of materials. That is not the aim of this particular session. But for the completion sake, I'll just take you through the materials that are commonly used. So conventionally, amalgams were used, but it is not recently advocated because of lack of biocompatibility, corrosion, hard tissue and soft tissue staining, and creating an amalgam tattoo. Next used was composite resins. Name is retroplast. Dentin bonding composite resins are used after amalgam. So you have hard tissue formation that is seen, but there are evidence of PDL regeneration. Composite is one of the good agent, but strict isolation for adequate bonding is mandatory. Zinc oxide eugenol based cement can also be used as an intermediate restorative material. It is more biocompatible, unmodified ZOE, that is the IRM type of ZOEs can be used. It has low solubility and has good antibacterial action. Calcium silicate cements such as MTA, mineral trioxide aggregate, which are currently very widely used. It has increased biocompatibility. It has cemento and osteoinductive property. So that is why it makes a more usable material than the other materials which I was mentioning before. It has the induction property of forming cementum and the bone. It has less inflammation, but the disadvantage is it is technique sensitive, handling properties and possible tooth discolorations are its disadvantage. Newer version of MTA is biodental, which is gaining its popularity, where it has all the properties of MTA and it overcomes the disadvantage which I mentioned. So once the retrograde filling is done, you have to verify it radiographically whether you have adequately resected the root surface and you have adequately created a seal in the periapex of that tooth. So once that is done, if area of defect is wider, and you can jump into a procedure called guided tissue regeneration. So but before doing a GBR or GTR, you make sure that that area is completely free of infection, because you are going to put in some material to regenerate bone. If there is residual infection, again this material is going to get infected and it is going to cause more trouble. It is going to cause a wide area of infection again. So the main aim of doing a GBR or a GTR is, once you have done the procedure, the cavity is going to be empty and you're going to close it with the soft tissue. So there can be ingrowth of the epithelial tissue into the area of a lesion where you have curated, and it is going to delay your bone regeneration, because over the bone or over the defect area, it is going to be only mucoperiosteum that you're going to redrape it. So to avoid all this or to accelerate bone regeneration, you can do this procedure of GPR, where the cavity can be filled with the bone graft, can be an autograft or commercially available allo or xenograft, and you can put a membrane to avoid soft tissue reattachment, and you can redrape it with the soft tissue. So it is used in the combination of membrane and graft. So once that is done, you have to reposition the flap and the wound has to be tightly closed, so that there is no seepage of saliva or infection. And if you're putting a graft or a membrane, it doesn't seep out and wash out. So monofilament sutures, not larger, it should be smaller in diameter, such as 5O or 6O, advocated so that the soft tissue or the mucosa is not injured that much. In aesthetic areas, you can use 6O or 7O, but you should have proper instruments to use 6O, 7O sutures, and loops might be needed. Otherwise, 4O or 5O is generally. Single interrupted sutures are better, advocated for better readaptation. And sling sutures can be used if you have used an intracellular incision. Sling sutures can be used for reapproximating the papilla in the posterior region. So let us see how this area where you have done surgery is going to heal. You have created injury, you have curated it. The body thinks that iatrogenically some sort of injuries happen from curating, root and resection, and even from flap opening, flap closing, whatever it is. So after that, primarily hemostasis happens in that region within days, and within weeks there will be inflammation. So hemostasis, initial vasoconstriction and platelet aggregation happens, and in the initial inflammation phase, neutrophil degranulation, macrophages migrate, and it will be taken, followed by inflammation will be the proliferative phase, where you have granulation tissue formation by fibroblast, epithelial cells, and new angiogenesis that is happening by the new capillaries in that particular area. And following month there will be remodeling, where you will have soft bone, the mature bone, and reorganization that are not happening. So this is just a glimpse of wound healing that is going to happen in the days, weeks, and months after your periradicular surgery. The post-operative instruction: meticulous oral hygiene should be followed, because you have put multiple sutures and perform surgery. So oral hygiene maintenance is very, very important. So you ask the patient to rinse with chlorhexidine-based mouthwashes, and postoperatively prescribe adequate antibiotics and analgesics. Sutures should be removed within 8 to 10 days by evaluating that the soft tissue has reapproximated properly. The outcomes of surgical endodontics based on Rood and Molvin's criteria. So radiographically and clinically, we can assess whether our endodontic surgery is caused complete elimination of the infection and resulted in good prognosis. So there should be reduction in the lesion size in the subsequent radiographs. Then there can be uncertain healing that is happening. If there is unchanged or the lesion is increasing, then it means that the lesion is not completely eliminated and you have unsatisfactory healing, wherein you have to redo the procedure. And this is all about clinical signs, whereas about previously mentioned is all about radiographic signs. The clinical signs are going to be absence of pain, swelling, tender on percussion, absence of tender on percussion, absence of sensitivity, or absence of sinus tracts. So all this can be a clinical indicator that your outcomes of the periradicular surgery is success. Radiographically, as I mentioned, the lesion should regress in size and bone should be forming in that region in subsequent radiographs. So for the new bone to be formed, or Only when new bone forms, the lesion can be in small in size or the radiolucent area is going to decrease. So for that to be seen in radiograph, for immediate periradicular surgery in days or weeks, this cannot be identified. So 30% of bone formation is required for it to be visible on the any radiograph. So ideally, you can wait for a month, 1 month to 3 months as a follow-up radiograph to assess whether the procedure is having good prognosis. So after 2 to 3 months, if size is decreasing and radiolucent area is decreasing, then you can wait and watch. You can take another radiograph in the 6 month and 1 year, and you can be put the patient on follow-up. But in the 3rd month radiograph or 6 month radiograph, as I mentioned before, if the lesion is the radiolucent area is of same size or it is increasing, then you have to intervene and eliminate the infection. So the complications that can result in endodontic surgeries are, there can be starting from the LA, there can be hypersensitivity to LA. So if the patient has done previous dental procedures, you are safe with LA. If not, do a patch test or a test dose before you do it. If you have not done and the patient has landed up in anaphylaxis, then we have to inject adrenaline, antihistamines like phenyramine maleate or hydrocortisone. And bleeding, the one thing is like if it is a bleeding from the granulation tissue, complete curating should arrest it. Or you can use local hemostatic agents, Abgels or tranexamic acids or adrenaline soaked in gauzes. Or if it is near a vital structure with a major vessel, you have to cauterize it or tie the vessel by clamping it. And scarring, most patients who have tendencies to develop keloids or hypertrophic scars should be washed post-operatively, and meticulous handling of the soft tissue and primary closure should be done. And infection, proper preparation, proper aseptic protocols should be followed to perform, not to escalate the infection or not to create further infection, and proper post-operative antibiotics. So these are the references. So let us quickly summarize what we have seen all now. So apicectomy is common day-to-day procedures that everyone can be doing in our dental practice. It doesn't need a specialist, only like oral and maxillofacial surgeons should be doing it. If you know the principles and if you know the steps to do it, even a dental surgeon can perform it. So we have seen the indications like where all this procedure can be used: failed endodontic restoration, and a large periapical lesion or a granuloma, which is for a chronic period of time, are the common indications. So the steps are the common incisions, advantage and disadvantage, the common flap that are used are discussed. The main ideology of incision and flap is proper access, visibility, and proper reapproximation to not land up in a scar or a gingival recession. Then the next step we discussed is all about locating the area of a surgery. If there are perforations, the body would have already located it, or the lesion would have already located it by creating fenestrations or opening. If not, bony window has to be created, which can be identified from the preoperative radiograph. So once the bony window is created, creating a bony window, care should be taken not to create a district unwantedly the large amount of bone. You keep it in minimal. But in the same, keep in mind, minimal doesn't mean you have to work in tunnel. Adequate exposure is also needed. Unwantedly, don't create an excess bony window because bone regeneration is going to be hampered. The next step is curate all the pathological tissues. Next, once that is done, go for root and resection. There we have to keep three things in mind: the instruments that are used, amount of resection, whether it is 1 to 3 millimeters based upon ramifications and lateral canals, and the bevel. It is now 0 to 10 degree bevel, keeping in mind to conserve the root structure to have adequate crown root ratio. Once all this is done, you inspect whether you have left something with tissues, whether it is left by using certain dyes, and you can monitor it. And then you can use a root and appropriate root and filling material, either an MT or a biodentin, which is recently gaining its popularity with good biocompatibility and these advantages. So you create a cavity in the root of adequate size, parallel to each other, whatever it is, whichever the endodontist must be good person to tell you about this. So once that is done, the root and filling material should be filled. So that has to be verified in the radiograph for adequate sealing and adequate filling. And followed by that, you can do a GBR, you can fill it with graft, you can put a collagen membrane and re-drape the soft tissue and meticulously close it. And post-operatively, you have to follow. Thank you for listening.